was built to last. With the webs I'm weaving, I could change the past. With all I'm achieving.
Hello everyone, welcome back to another video on the channel. We're going to go ahead and get started today with the pulmonary and critical care section of the ABIM. These are questions generated by ChatGPT AI to basically test high-yield educational objectives from the MCASAP, UWorld, and ACP. These are all AI generated. I'll show you how to do these, and you will need to give a very specific instructions for it to create comprehensive questions that are most similar to board exams. And so let's go ahead and get started with the first question. This is a 54-year-old male with a history of alcohol use disorder, GERD. He presents with a 3-month history of chronic cough, fever, night sweats, and weight loss. He also reports foul-smelling sputum. On physical exam, he appears mildly ill with a low-grade fever. His lung examination reveals decreased breath sounds in the right lower lung field. A chest X-ray shows a cavitary lesion with an air fluid level in the superior segment of the right lower lobe. So which of the following is the most appropriate first line management? All right, so go ahead and pause the video right here, pick your answer, and then we're gonna go through. All right, so this is a patient presenting with a lung abscess, correct? So a lung abscess resulting in necrotizing pneumonia, most commonly associated with aspiration of oral anaerobes, and these bugs are Streptococcus, Fusobacterium, Prevotella, and Bacteroides. Patients with impaired consciousness, alcohol use, dysphagia are at high risk for these ineffective because of their ineffective airway clearance. The key clues were that the patient has chronic symptoms, right? It's weeks to months, foul-smelling sputum, most likely related to anaerobic infection, and then a cavitary lesion with air fluid level and on chest X-ray, which would be the hallmark of the lung abscess. The answer choices. So the first one, azithromycin, that's totally wrong. It's used for mycoplasma, atypical pneumonias, which do not present in any way close to this. Ripe therapy, this was if you had a suspicion for TB, with the typical cause being apical lung cavitation, and then not in the, the dependent lung zones. And again, you need to look at the epidemiology and see if this patient is really at high risk of having TB before you start him on empiric therapy. Peptazo, it also covers Pseudomonas. It is good, but it's not. It's going to be overkill for this reason. So the best one here would be the ampicillin sublactam. This is the first line treatment against anaerobic and polymicrobial lung infections. Clindamycin, it's less favored now because of the C. diff risk, as well as it's reserved for specific cases. Right now we see it a lot in more of the dermatologic issues, cellulitis, and things like ENT infections, more than actual infections in the hospital with anaerobes and lung abscesses. So the algorithm was that, identify the risk factors for aspiration in this patient. Realize that he has history of alcoholism, dysphagia, it has alimentation. Confirming the diagnosis with imaging, take a look at the cavitary lesion that has air fluid level, and think about your coverage with antibiotics, and go through the pattern recognition. So chronic cough, foul smelling sputum, think about this anaerobic infection, and then again cavitary lung lesion with the air fluid levels there. Reviewing the latest guidelines, again, that's a preferred treatment, and there's no need for surgical drainage unless a failure to improve the antibiotics. All right, it's a pretty fast and easy question, so let's go ahead and move on to the next question. All right, so this is a 45-year-old woman with a history of asthma. She presents with a 3-month history of progressive dyspnea, chronic cough, intermittent wheezing, night sweats, and weight loss. She denies smoking history. On exam, she has no signs of acute distress, and lung auscultation reveals diffuse bilateral wheezing. Laboratory studies show an elevated eosinophil count of 12%. A chest X-ray reveals bilateral peripheral opacities, sparing the central lung fields. Which of the following is most likely the diagnosis? So looking at it, the 3-month history of this presentation with eosinophils, go ahead and pick your answer, and then we're going to go through the options together. All right. So this is a question about chronic eosinophilic pneumonia, or CEP. It is an idiopathic inflammatory lung disease. It's characterized by eosinophil accumulation in the lungs. It often occurs in non-smokers as associated with asthma. It presents insidiously over weeks to months with constitutional and respiratory symptoms. The peripheral eosinophilia and the bilateral peripheral lung opacities on imaging are the key findings in this case. The difference between the chronic versus the acute would be the onset, and then the how long it's been there. The eosinophilia, greater than 10% there, will tell you that there's some sort of eosinophilic lung disease. The peripheral lung infiltrates, sparing the central, is pathognomonic for CEP. The AEP is the more acute. It's days to weeks. CEP is the gradual onset and has the peripheral opacities. The eGPA goes into the periphery of the basically the vasculitis, right? So it's associated with other findings like mononeuritis and other systemic findings. Hypersensitivity pneumonitis, that typically presents without eosinophilia, and the infiltrates will be just diffuse, not peripheral. So this is how the boards are gonna test these questions, is based on the way the infiltrates are and how they commonly present. Tuberculosis, that would be cavitary or nodular infiltrates and not associated with eosinophilia commonly. And then the looking at clinical decision making, again understanding the onset, is it days to weeks, weeks to months, and then having also just looking at the onset, right? Any differential diagnosis is equal to localization times time course, which is a very good way to think about things. If you just look at the time course and all these other options, you could divide these options into how they would present based on time course. For example, AEP, infection, hypersensitivity, pneumonitis, these are more kind of a days to weeks presentation. The chronic presentation diseases would be like the CEP, the EGPA, the TB. Those would be more chronic. Now, then you think about, okay, which of these lung diseases can have a lot of peripheral eosinophilia. So when you look at that and divide them up, you see that CEP, AEP, EGPA, those are diseases that can involve the lungs and present with eosinophilic findings. And the other causes are less likely to do that. For example, TB, hypersensitivity pneumonitis, cancer, ILD, they're not going to present with the eosinophilic findings. So what does the imaging show? Then based on the imaging and the location of the opacities, is it something that is sparing the central area? Then in that case, you can also take that as a clue and to be in CEP because it prefers more of the peripheral opacities. Diffuse opacities, you may have the AEP and the hypersensitive pneumonitis. The cavitary lesions, you can see them with vasculitis involving the lungs, or TB. And then the pattern recognition is very important, right? Sometimes they may say photographically negative, of pulmonary edema, or they will tell you peripheral opacities. You think about CEP. If they tell you some chronic core, someone with history of asthma and eosinophilia, then you can think about CEP. If they tell you, hey, this had these findings and they had rapid response to steroids, that you can think about is most likely going to be CEP or AEP, because the latest American guidelines are treatment of glucocorticoids with prednisone for 3 months with slow taper over the 3 more months. Although they respond very well, there are still relapses that can happen, so up to 50%, but will require a little longer term kind of course of treatment with steroids. Okay, so that's another high yield question. And moving on to the next question. So this is a 50-year-old Caucasian male, okay, with a 3-month history of nasal congestion, recurrent epistaxis, and cough. He also reports fatigue, unintentional weight loss, and joint pain. On exam, he has crusted nasal ulcers and mild inspiratory stridor. Lab studies show an elevated ESR and CRP. Urinalysis is showing hematuria and red blood cell casts. A chest x-ray demonstrates multiple bilateral capillary nodules. So this is one of those presentations that you have a lot of systems involved. So which of the following is most likely diagnosed? This is a first order question. So go ahead and pause the video right here, pick your answer, and then we're going to go through each of the options together. All right. So when you go through pathophysiology, of course, this is granulomatosis with polyangiitis, or GPA, or previously called Wegener's granulomatosis. It is a necrotizing vasculitis. It affects the small and medium-sized vessels. It is characterized by upper airway disease, like this patient had, the sinusitis, epistaxis, saddle nose deformity. Now, the boards may only tell you about the sinus problems and recurrent sinus infections, or they may tell you more subtle things. Lower respiratory tract infection, maybe cavity nodules, and could be bilateral. And then in terms of the nephritis, you will have a glomerulonephritis that is mostly associated going to be the hematuria, the RBC cas. So the key clues here were that there were chronic nasal symptoms, okay? And then you also had pulmonary nodules and cavitations. And then you also had a glomerulonephritis. And if you were to think about like CEP, of course, we're wrong, because that's not associated with any other system involvement. EGPA, this would present with the eosinophilia, maybe even a mononeuritis multiplex. And then the distribution of the disease is also different. The GPA, which is the correct answer, is the triad that has the upper airway, the lungs, and the kidneys. The good pattern would have the pulmonary hemorrhage and a rapidly progressive maybe glomerulonephritis, right? So but no upper airway or cavity lung lesions. TB again would not have the sinus, epistaxis and all, and the glomerulonephritis would be very typical. So does this patient have upper airway, lung, kidney involvement? You should know that these three organs together are probably GPA. And does this patient have eosinophilia? Then you may think about more eosinophilic multivascular diseases like EGPA, although the CEP is only lung findings. And then what does the imaging show? Is there peripheral opacities? In chronic eosinophilic pneumonia, you would have that. Again, if you didn't have the other system involvements, you would think about this. If you have bilateral cavity nodules, it's most common to be GPA, even more than TB in this case. And so kind of thinking about pattern recognition for boards, these are a lot of things for boards. Not in practice, you need to pay attention to more subtle things when you're practicing. But the sinusitis, cavity lung lesions, and glomerulonephritis, which would be in this case a post-immune nephritis, you think about the GPA. If you have a positive C ANCA or PR3 ANCA, again supporting GPA. If you have RBC cas in the urine hematuria, you think about vasculitis. And the American guidelines suggest that the C ANCA with the PR3 ANCA, basically this one is positive in 85 to 95% of cases of GPA, and the tissue biopsy confirms the diagnosis. The treatment could be rituximab or cyclophosphamide plus steroids, and then maintenance therapy could be, azathioprine or methotrexate. All right. So this with this one, we are at the end of our session. Again, remember that the key to learning these things is learning in small bits. Our goal with these lectures is we work in small bits, only focus on high yield and educational objectives from the board exam, create our own questions, and go from there. And then I have these notes all posted for you guys on my Patreon channel, so you can follow that and become a member over there. Follow me on Instagram. I would really appreciate if you like these sessions to drop a like, subscribe, so I can keep doing this every day for you guys. So thank you so much for being here to the end. I'll see you on the next one.